Our next speaker is Eden Brower. She is an assistant professor here at UCLA, at the UCLA School of Nursing. She is a nurse scientist who studies and is an expert in cancer survivorship and new trends and directions in cancer survivorship care. I saw Eden give a talk last year at our Cancer Center symposium and thought it was awesome and said we've got to work closer with Eden, who I've known for a while through our kids. Her work is also supported by the Hirschberg Foundation, and I'm sure you'll enjoy hearing what Eden has to say today about pancreatic cancer survivorship. Thanks, Eden.
Okay. Good afternoon. Can you hear me okay? Okay, and thank you so much for the warm introduction. Thank you to the Hirschberg Foundation and the organizers for inviting me to be here today. I'm very excited to be here to talk about survivorship care in pancreatic cancer, and I'm hoping to begin, let's get this set up. I'm hoping to begin by sort of providing some broader context on the field of cancer survivorship science and survivorship care, and then discuss that in the context of pancreatic cancer, and finally share a little bit about some of our efforts that are underway at UCLA to really put these ideas and principles into practice for our patients. Okay, so as we begin, I always think it's important to just start with how we define cancer survivors to get us all on the same page. The most widely accepted definition now comes from the National Coalition of Cancer Survivorship, an advocacy organization that was founded by and for cancer survivors. And this definition has now been adopted by many others, including the National Cancer Institute. And it states that an individual is considered a cancer survivor from the time of diagnosis through the balance of life. And it's important to point out a few things. First, the term survivor resonates positively with some individuals and really doesn't appeal to others. And there are ongoing conversations about this. I've worked with many people, patients, families, clinicians over the years, and they've said, you know, this work is so important, but I just hate that term. And so I just think it's important to acknowledge that up front. I recommend doing so with patients as well, you know, and kind of asking them, letting them decide how they would like to discuss these aspects of their care. It's certainly not a perfect term. But hopefully my talk today will really focus more on its meaning. And second, it's important that I point out that this definition has evolved over time and really reflects more contemporary thinking by locating the start of this cancer survivor experience not at the end of treatment, meaning that it's something that is limited to only some patients, those who can receive curative treatments and tolerate them and achieve some sort of remission from them, but rather at the time of diagnosis, and therefore inclusive of all experiences that follow. So that has major implications for us when we think about survivorship care. Again, but this is something that we should be thinking about essentially for all patients from day one, from the point of diagnosis onwards, with a focus on how this disease and perhaps also the treatments we use to treat this disease impact quality of life, not just in the short term, but really throughout life. And frankly, this represents a major paradigm shift for oncology care. So why is that? Why does this represent a shift, and what were some of the factors driving this shift? If we consider the historical context, the whole field of cancer survivorship is still relatively new. It's only been as a result of improved survival rates that we can even begin to understand the unique needs of cancer survivors. So this shows some key milestones along the way, starting in 1986 when the National Coalition for Cancer Survivorship was established. Then, a whole decade later, in 1996, the Office of Cancer Survivorship was formally established within the National Cancer Institute. And at the launch of this office, President Clinton said, "Cancer survivors have special psychological, physical, and healthcare counseling needs that we are only beginning to understand." So this was really still a new frontier, and it took a lot of tireless advocacy to make this progress. And then you can see, only a year later, the Hirschberg Foundation was started, true leader in this regard. Yeah, I was really excited to add this to this timeline. Really impressive. Then another whole decade passed before the Institute of Medicine released its landmark report called From Cancer Patient to Cancer Survivor, Lost in Transition. This report was the first to really articulate the broad issues that cancer survivors were facing scientifically, particularly some of the chronic effects of the standard cancer treatments that we were using all the time, like chemotherapy and radiation therapy. It also described a sort of cliff or drop-off that patients felt after cancer treatment, for which they felt completely unprepared and unsupported. Around that same time, the group at St. Jude's started publishing their results from large cohort studies of childhood cancer survivors, another growing group of survivors with, again, very distinct needs. And they showed that childhood cancer survivors experienced ongoing functional loss even as they were transitioning to adulthood and decreased ability to participate fully in their lives. Then finally, 2 years later, another key report was released called Cancer Care for the Whole Patient. And it really made the case for psychosocial support as an essential piece of cancer care. It claimed that cancer care often provides state-of-the-science treatment, but fails to address the psychosocial problems. And these problems not only cause additional suffering, reduce adherence to treatments, but also threaten patients' return to health and quality of life. Finally, around this time, there was also some very exciting research going on in terms of early involvement of palliative care. So meanwhile, throughout this entire period, there were also major advancements in modern treatments taking place. And so I'm going to talk about each of these things briefly, these various factors, to sort of provide a sense of where things started and how our thinking has evolved. And so these early reports that were revolutionary at the time, they proposed this diagram to illustrate the entire cancer care trajectory, to emphasize that the cancer care trajectory was not just diagnosis and staging and then treatment with intent to cure, but also included these other phases that desperately needed our attention, particularly the post-treatment challenges seen here in this pink circle, the sort of aftermath of cancer and its treatment. And the challenges people faced when they were trying to pick up the pieces of their lives, the psychological consequences, and also the ongoing medical needs often related to chronic toxicities from the life-saving cancer treatments that they received. And basically, they were pointing out that even in these best possible scenarios with cancer-free survival or well-controlled disease after curative intent therapy, people were finding this very challenging to manage, and the healthcare system was failing to provide adequate support and was really leaving people to fend for themselves. So these reports certainly raised awareness and spurred research efforts that was very much needed at the time, but the focus of survivorship was not necessarily about starting from day one. At that time, survivorship care was much more restricted to patients who were in this pink circle, post-treatment and without detectable disease. In parallel with these efforts were dramatic demographic trends. This chart shows the number of cancer survivors in the US over time starting at 1977 to 2022. And so another reason that survivorship is still relatively new is because we didn't really have to confront these issues until pretty recently. Advancements in early detection, treatment, and supportive care have led to rapid increases in the number of cancer survivors. And of course, such rapid improvement represents a major success story, right? Currently, there are over 18 million cancer survivors in the US alone. And by 2040, This number is projected to increase by another 8 million, reaching 26 million. And just a few weeks ago, the American Cancer Society just released projections that the number of new cancer diagnoses is expected to reach 35 million by the year 2050 globally, which will be a 77% increase from 2022. So this population is new and growing fast. Here we can also see another really important trend over time. Not only is the overall number of survivors growing, but now we have this newer phenomenon of long-term survivors. And some are very long-term survivors, seen here in the purple and blue bars, living more than 10, 15 years past diagnosis. Again, another huge success story, but with important implications for survivorship care, what it means, and how to best support health and wellness long-term. So this chart shows the same general trend, but using even more recent data, and I put it here because we can see that we're now tracking even longer periods of time. The previous graph showed survivors who were far out as 15 years from diagnosis, but in just the past few years, we've begun to monitor data for long-term and very long-term as far out as 20 and 30 years post-diagnosis. And you can see there are about 1 million people in each of those very long-term groups on the far right. So we can see that the focus on that immediate post-treatment period is getting a little bit more ambiguous. We know many of these individuals have very chronic issues related to their disease and treatment. And so again, this population of survivors is a relatively new phenomenon, an exciting phenomenon, but we need to better understand their needs and really think about that when designing survivorship care programs. Another important trend over this same time period is revolutionary advancements in cancer treatments. This timeline highlights major turning points in modern oncology, starting with the period from 3000 BC to 1890, when surgery was our one and only option. And then in the early 20th century, we see the introduction of radiotherapy and chemotherapy. But then in the 1980s, around the same time we're talking about, we see this major breakthrough with the introduction of molecularly targeted therapy, then immune checkpoint inhibitors and CAR-T. We've also seen rising uptake of multimodal treatments where we're combining different modalities, right? And so this was not just new drugs, but whole new treatment paradigms that were resulting in durable response and even cures for historically poor prognosis cancers. This is important when we're discussing survivorship care because not only are we focused on the effects of the disease itself, but another major focus is on the effects caused by the treatments we are relying on to target the cancer. So often these are extensive, and with new treatments comes new treatment effects to consider. So for these increasing numbers of cancer survivors, early detection has been so critical. But so has treatment. These new therapies and new combinations of therapies have also contributed to the growing numbers of survivors, and we are now observing marked increases in the numbers of individuals living with advanced and metastatic cancers for extended periods of time. Recent data demonstrates this. As you see here on the left, we see the increasing number of patients living with metastatic breast cancer. Then the graph on the right shows the decline in lung cancer deaths. And as you may know, about half of lung cancers are diagnosed at advanced stages. But now we have expanded our treatment options beyond just platinum-based chemotherapies to include immunotherapy and targeted therapy. And so this has really changed the survival patterns we observe for these patients. Once again, this is a new and heterogeneous group. Individuals living with advanced or metastatic cancers, they may cycle on and off treatment, they may have periods with and without active disease, and they may be receiving targeted therapies, so there's really no clear end of treatment or transition to post-treatment. It was only about 1.5 years ago that the National Cancer Institute held a workshop focused on the health and supportive care needs of this population, people living with advanced and metastatic disease. And certainly this is a little out of sync with that early focus on the post-treatment phase. So this too has sort of challenged our traditional understanding of who is a cancer survivor, who needs survivorship and supportive care, and what that care should offer. So all of these combined forces coming together also spurred survivorship research and development of clinical programs, which helped us to understand the ongoing consequences of cancer and its treatment. And this can apply to individuals across a wide range of scenarios with respect to disease type, clinical stage, prognosis, time since diagnosis. Here in this figure, we can see some of the issues that are common across cancers on the outermost ring. Physical and functional problems, including chronic pain, lymphedema, cognitive impairment, and the potential impacts of some of these issues along the inner ring. The social and financial challenges with resuming employment or maybe not being able to, role disruption, isolation. So these issues can be quite multidimensional, spanning across physical, psychosocial, functional, and practical domains. And they're also not static, right? A patient's supportive care needs change and evolve over time, especially when we're talking about from the point of diagnosis onwards. And so there's also not always a linear recovery. Sometimes we assume that the effects of acute treatments will just improve with time and healing, but sometimes that's not true. Sometimes things get worse or new things arise. And there may be significant transition points in this trajectory too, related to the disease, maybe introducing a new therapy, maybe experiencing a recurrence, or maybe just the cumulative emotional effects of the experience finally catching up. And so needs are changing within broader health and life circumstances, and all of that is occurring within this context of family, loved ones, and caregivers, all of whom are also greatly impacted. We also see important patterns of common cancer-related symptoms. A recent study of more than 31,000 cancer survivors found that symptoms are common, they often co-occur, and unfortunately, they are very under-recognized and subsequently undertreated. On the left, you can see a network analysis of multidimensional symptom experiences within this sample to try to understand these co-occurrences and patterns of common symptoms. These are things like pain, physical function, impairment, anxiety, sleep disturbances, fatigue, issues that occur in many, many people. And they found that up to 65% of patients exhibited 3 or more of these symptoms at any time, depending on what combination you looked at. And so this is a very common phenomenon, and it really is the clustering of these effects. So when we're thinking of how best to provide care, we can see that one-to-one symptom assessments and one-to-one interventions are probably not the best strategy. We also know that the underlying biological mechanisms can be related through inflammatory pathways, for example, and so this is also important when we're thinking about how to intervene and manage these issues. And so what you see here, this dynamic, multidimensional symptom experience, is a little more reflective of the patient experience and what we see clinically, but it also adds to some of the complexity of managing this experience well in practice. It's definitely not one size fits all. A tailored, individualized approach is really needed, and so is a multidisciplinary team. And finally, another piece, a really important piece of the historical context during this time that was influencing our understanding of survivorship was groundbreaking research on the early integration of palliative care. These charts are from a seminal study by Dr. Temmel and colleagues at Dana-Farber, and they examined the effect of introducing palliative care early after diagnosis in patients with metastatic non-small lung cancer. Study participants were randomly assigned to either the study arm, which included early integration of palliative care, or standard cancer care as the control arm. And when they compared these groups, they found that those in the early palliative care group reported significantly better quality of life, significantly lower psychological symptoms of depression and anxiety, but also significantly longer median survival. So although this study was small, it really had an impact in opening the medical community's eyes to the benefits of integrating palliative and supportive care early in the cancer course, ideally around the time of diagnosis. And these benefits were evident even in patients with some of the most challenging diseases. Since this study, these findings have been reproduced in several other randomized controlled trials in patient populations with other advanced cancer types. And this has led to the development of clinical guidelines in this area and strong recommendations by other major entities for early integration of palliative care. So if we sort of synthesize all these key concepts and learnings over time and use this to inform survivorship, you can see how we have sort of arrived at this more contemporary understanding that someone is a cancer survivor from the day of diagnosis through the balance of life. Then we sort of see how we've really moved to this more expansive framework of supportive care across the cancer trajectory, in which the goal is to improve quality of life of people with illness by preventing, so really early, or treating as early as possible symptoms of disease and side effects caused by its treatment. At the time of diagnosis, we're able to ascertain many factors that will influence that individual's risk over that trajectory. Comorbidities, performance status, cardiometabolic function, behavioral factors, baseline symptom burden, and use this information to promote the best possible outcomes. So all of a sudden, it's kind of hard to imagine not starting at diagnosis. I've also included this fascinating diagram from a recent article by leaders in the field of supportive care, and it really tries to depict the interplay between diverse and varied supportive care needs that patients may experience, things like symptoms, side effects, psychological distress, information needs, caregiver support, seen here in the blue shapes. And it also shows the multiple supportive care services that are needed to be involved across the entire cancer trajectory, like symptom management, palliative care, pain management, psycho-oncology, survivorship. These are all represented by different colored cylinders that overlap with different phases, and so this diagram really shows the role of supportive care across these different changing clinical circumstances. But in its complexity, I think it also alludes to some of the challenges in delivery of supportive care and in doing it really well, in identifying those supportive care needs and connecting patients to supportive care services efficiently, optimally, and equitably in the realities of our clinical environments. So, what does all of this mean in the context of pancreatic cancer? So, most of us know pancreatic cancer is unfortunately an aggressive malignancy. One of the biggest challenges is that most patients are diagnosed when the disease is more advanced, and because of that, curative treatment is not available. As with most cancers, stage and progression of disease are closely linked to prognosis. On the left, you can see the most recent data from the SEER database showing the distribution of cases by stage at diagnosis, showing that only 13% of patients have localized disease at that time and the opportunity for curative resection. Although this morning's talk, I will say, gave me chills just hearing about the innovations in screening programs and sort of the speed at which that's happening. On the right-hand side, you can see the breakdown by stage over time from 1975 to 2011 with localized disease in green. And you can see it's really been challenging to move the needle when it comes to those green bars without solid early detection methods. And in some ways, this leads to sort of distinct trajectories with treatment paradigms that are stage-specific and widening differences in survival outcomes within pancreatic cancer. And with that, also some variation in terms of the supportive care needs patients and families may have. So moving forward, the goal is to develop flexible, comprehensive supportive care programs that can encompass all of these varied experiences. As difficult as it is to think about survival rates in the context of pancreatic cancer, and although these rates are nowhere where we want them to be, this chart does show signs of progress in a more hopeful direction to me, particularly with a steepening curve upwards in more recent years. It is true that for most cancers, there have been notable improvements in survival rates, primarily due to advancements in treatment and early detection, but not for all. We still have some cancer types where survival rates have remained totally stagnant, and some that have even worsened over time. So, of course, we're working towards and hoping for massive leaps here. I love the goal that was set this morning. Of course, but this improvement is a sign of progress worth acknowledging. And to be perfectly honest, it's not often that I am asked to speak on survivorship specifically for pancreatic cancer. And so for me personally, this is also a sign of progress for the field and advancing our care. Continued attention on more opportunities for early detection, both in those high-risk screening programs and developing screening strategies for broader groups of people, is of course one of the highest priorities, and that will really impact these numbers. However, as we saw earlier, new treatments and treatment combinations can also make an impact by extending survival time for individuals with more advanced or metastatic disease. We're seeing new therapies allow people to live for much longer periods of time with high quality of life and functional levels in almost unimaginable ways. And so for pancreatic cancer, we remain focused on both innovations in surveillance and imaging approaches for early detection, as well as advances in systemic therapy and particularly precision oncology to enhance both quantity and quality of life in our patients. So here I've adapted our earlier graphic for pancreatic cancer. As with many cancers, there are some issues that are sort of cross-cutting, like fatigue, while others are really unique to specific groups of patients, the symptoms they experience, the treatments they receive, and so there's a need for a more disease-specific and sensitive lens. Although there's not a ton of research on pancreatic survivorship per se, there are studies that have begun to describe the quality of life concerns and the supportive care needs of this group, and we have drawn from those. We know that individuals with pancreatic cancer can experience significant symptom burden, and this can also vary person to person, of course. They may need complex symptom management interventions targeting common issues such as pain, weight loss, depression and anxiety, gastric obstructions, ascites. We also know, as I touched on before, that often these symptoms can co-occur or cluster. Physical symptoms like pain and nausea can impact mood or sleep and vice versa. So this holistic approach can be really valuable in understanding those overlaps and sort of what they mean for specific patients. Among patients with pancreatic cancer, the psycho-emotional aspects cannot be overstated, particularly with respect to depressive symptoms. There may be feelings of unfinished business or spiritual distress, and unfortunately, the risk of suicide is much higher when compared to other cancer types or the general population. So screening and treating distress and depression is crucial. Another really important, sometimes underappreciated aspect is relationships, particularly with loved ones who are in a caregiver role. Informal caregivers are now considered an extension of the healthcare workforce, given the extraordinary levels of responsibilities and time we require of them. It's estimated that they spend an average of 32 hours a week providing care, and that 72% of that time is spent performing what's considered complex medical or nursing tasks. They are usually sort of thrust into this role without any preparation, and this can be tough in so many ways. There may be challenges or even conflict present in balancing caregiving responsibilities and health changes, and even a sense of loss with the relationships with their loved ones. However, the scope of supportive care, by definition, encompasses helping the patient and their family and loved ones cope with cancer and its treatments across the illness trajectory, and involving caregivers and tending to that relationship starting early. Building that trust and foundation is also really critical. Many of the effects of cancer and its treatment on the left side can also result in functional limitations where daily activities are impacted by these health changes. And functional status is considered a key indicator of health-related quality of life. This graph is from a recent report using NHIS data to examine trends in the prevalence of functional limitations over this 20-year period. And when they compared cancer types, they found the highest adjusted prevalence of functional limitations in survivors of pancreatic cancer. It was about 80% in this group. It was close to second runner-up was lung cancer at 76%. However, it's worth noting that even in the groups with the lowest functional limitations, those were melanoma, breast, and prostate, the prevalence was still about 60%. So functional impacts are common in people who have had cancer, and clearly there's a role for supportive care for all, regardless of cancer stage and prognosis, and for early initiation of supportive care to improve long-term functional status. So for the last few minutes, I'll just share some ways that we're trying to really put this into practice at UCLA and ensure that our programs reflect these key principles. High quality cancer care means ensuring patients' supportive care needs are met from the day of diagnosis onwards, right? Hopefully you'll take that away. But as you might imagine, or maybe have even experienced, this is complicated to carry out and there are a lot of barriers. And so what we often see in routine care is that supportive care comes in late, or it's limited, or it's fragmented, and ultimately it does not reach all the patients that could benefit. In fact, research tells us that symptoms in patients with cancer go undetected as much as 50% of the time in clinical practice. So if we're failing to identify symptoms, then it's very unlikely that supportive care will reach those patients. And often we're using a very kind of reactive approach to symptom management, what I call a whack-a-mole approach, and waiting to address symptoms later, not until patients are really struggling and becoming highly symptomatic. But as I've been discussing, there's this growing recognition that earlier, more proactive integration of supportive care will improve patient-centered outcomes. And so we're trying to align our efforts at UCLA with some of these ideas and trying to design systems and programs that facilitate early integration of supportive care and also optimizing the teamwork that you need to do this across various clinical departments, both on the oncology side, but also on the supportive care services side. So this is from a current project in which we're taking a proactive approach by systematically screening patients and asking them to complete brief supportive care assessments early, usually around the time of diagnosis or treatment planning, and then conducting repeated assessments over time, similar to what you heard about earlier. The approach is patient-centered in that it incorporates the patient's own report, which, by the way, is considered the gold standard in symptom assessment and function, into an overall clinical picture. And it's also intended to be pragmatic. The tool is fully integrated into the existing EHR, the electronic health record, and it's designed to fit within current workflows and leverage the institutional resources that we have at UCLA, but the dots are not always connected or coordinated very well. So that includes some of our very specialized supportive care services. The tool has been designed to include a core symptom screening that assesses some of those common cancer-related symptoms we talked about earlier, as well as a disease-specific component to capture concerns that are unique to that group. So you can see here nutritional status, as we've been talking about. It can be adapted for different groups of patients. But it also has built-in clinical decision support to streamline the process for really busy clinicians by providing tailored, actionable recommendations and referrals in real time. Not all of them are listed here, just some of them to give you a flavor, and the supportive care services have been amazing collaborators on this as well, helping us develop appropriate pathways and referral criteria. Over time, this tool will also facilitate ongoing symptom monitoring and longitudinal tracking of supportive care patterns across the care continuum. And it will also support a more cohesive, less fragmented approach to supportive care, especially for our patients who are being followed by a variety of teams. We've already implemented this system in our head and neck cancer program across medical oncology, radiation oncology, and surgery clinics. And now we're preparing to do so in many other clinics, including some of our GI clinics, our breast survivorship clinics. So this is a really exciting example of how we're implementing best practices in supportive care. And lastly, another effort I just wanted to briefly mention is expanding our clinical research on aspects of quality of life in the context of pancreatic cancer, including the impact on relationships and especially those with loved ones who are acting as caregivers. So we are now recruiting for a pilot study that is generously supported by the Hirschberg Foundation to explore the use of mindfulness-based practices and interventions for patients with pancreatic cancer and their caregivers, as well as just to better understand their supportive care needs. And so this study really builds off a growing area of research on mindfulness that has demonstrated a wide range of health benefits, including in individuals with cancer, but unfortunately, many of the available programs are fairly rigid or time-intensive and just may not be feasible for individuals with more advanced cancers and their caregivers. And so the idea here is that we've worked with a team to develop a set of modules that you can do at your own pace, on your own time, and really let us know if this is something that supports you and your caregiver or vice versa. And this study is with my colleagues in the School of Nursing, as well as a collaboration with clinical teams at the IPU here, the Aggie Hirschberg Center of Pancreatic Disease, and the Sims-Mann Center for Integrative Oncology. But it's also open to individuals who are not receiving their care through UCLA. So if you're interested in learning more, we'd love to connect, and please either contact me or there's some info in the lobby. So with that, I just want to close by saying thank you so much for being here today. Thank you for allowing me the opportunity to be here today, and I'm happy to hear any questions or comments, or you're welcome to contact me at this address.
That was excellent, really informative and comprehensive. And given your role that you oversee sort of different disciplines and different cancers, when you think about supporting, like you said, it's complicated, but there are similarities, right? So I think when we think about GI cancers, and there's differences and there's similarities. So as you think of it from a cancer center perspective, so getting different disease sites to work together to help raise awareness and maybe financial support to further support these programs, it's not an easy endeavor, I would assume, but
not
maybe
easy.
So I think, if you think about it, you have Tim, who's a champion here in pancreas cancer. I guess it's a lot of work, but thinking about how you bring together those champions and support, and also dietitians, and a lot of you guys span different cancers. So I'm not asking an easy question, but just recognizing the opportunity space of how to get sort of raise that awareness at the Cancer Institute level, and then maybe have resources that would then kind of flow into the different groups.
Yeah, thanks. It's such an important question and such a major challenge. I think part of it is really institution specific and how an institution operates. Obviously here we are a massive health system, and we're spread, as we talked about earlier, we're spread all across California at this point. And so I think moving forward and kind of where things are at now, it's really thinking about what are our common resources and our common supportive care services that we need everyone to be able to access, and thinking about organizing those, but also giving, we're big enough that disease teams and clinics can have autonomy to shape what their survivorship programs are going to look like. And so that's where the disease-specific kind of flexibility comes in. But why do only some patients know about these resources? Well, so some of these common resources we all need to be sort of directing patients to in a more systematic fashion. And so I think that's one thing. And then the other thing is just making all of this more accessible outside of Westwood, realizing that we have tons of oncology satellite clinics, palliative care satellite clinics, but even people can do so much in their home, and there's a lot of survivorship care that doesn't require these sort of highly specialized supportive care services, but we need ways to identify those who do need to come in, and then also support those who may not need that high-touch care. So, yeah.
Great, thank you so much, Eden. That was wonderful.